And we have a selection of neonatologists. Our fellows are all in one room, so they're you can see some of them there, and one of our nurse practitioners. And I'm sure other people will be, two of our nurse practitioners, and other people will be floating in, I'm sure. So thanks for coming to talk to us, because we're all very interested in how this goes.
Okay, so if you're ready, I'll just go ahead and get started. And the one thing I just want to make sure everyone has some muting of the mics, or I'll just remind you, occasionally there've been times people have taken a portable laptop into the bathroom, and I said, can you mute it while you're flushing the toilet? So kind of gets a little bit embarrassing. So I'm going to talk about advances in the limits of viability from fetus to neonate 22 weeks gestation. And I have here on the cover a set of our 22 and 1/7 week twins that were basically clearly AGA at 22 weeks. And this is them at a couple years of age. And the interesting thing, they had been the earliest, most premature twins, but now there's a set that was from Toronto that was born one day earlier. And so it's exciting to see that the ability to care for babies at this level of prematurity has accelerated throughout the world. Okay, nothing to disclose. So the objectives in this talk is we're going to look at differences in culture and philosophy when caring for infants born at 22 to 23 weeks gestation. This is an important point because if the culture is not set up, if the belief is that these babies cannot survive, they will not survive. And if the belief is that they're going to do poorly long-term, that same thing will result. The second thing where we'll spend the most time is to identify differences in management strategies when caring for infants born at 22 to 23 weeks gestation. This is a very unique population, and when we try to duplicate our success at 26 weeks without changing a single thing at 22, it fails. And importantly, we're going to describe both short and long-term outcomes of extremely premature infants born at 22 to 23 weeks gestation, and what I call is managed with a proactive, standardized, and balanced approach. And balanced is really critical because you have to sort of balance lung protection and brain protection. Well, which one should really come first? Obviously, brain protection needs to come first. And standardization is important because you can't have 4 different ventilator approaches to the management of these patients. When caring for 22 weeks babies, I always think about the Apollo 11 moon mission from over 50 years ago. And you sit on Earth at night and you look up to the moon, you think, gee, that must have been hard and must have been difficult. And clearly, prior to 1969, it was impossible. And the key thing about the moon mission, the Apollo program, wasn't Neil Armstrong and Michael Collins and Buzz Aldrin, but it was literally the hundreds and thousands of people supporting this program. And one of the interesting things is when the astronauts were heading to the moon on the landings that we've done at the US, they did a lot of micro adjustments during that whole transit. So I think about that the same thing in the first week of a 22-weeker. The transition phase is basically as similar to the moon mission. You got to do a lot of micro adjustments on the way there. So survival is improving for premature infants born at 22 weeks. There was a long period of time where people thought this basically was impossible. As you can see from the Vaughan data here, survival hovered basically around 6–7%, and only about a quarter of our centers offered even the opportunity to attempt after treatment. And in 2015, things started to change. And you can see from 2014 to 2019, the survival went up 3-fold. Of all the 22 weekers born, and the number of centers basically doubled that were offering active treatment. Now, the main thing that happened in 2015 was an article came out in the New England Journal that discussed that survival was possible at 22 weeks, looking at the neonatal research database from the Neonatal Research Network. The New York Times Magazine picked that up, and more people began talking about this and what were the approaches that led to the survival. Now, The other thing to also look at is you want to look at survival, not just based on whether all hospitals, because if you don't offer active treatment, survival is 0. So looking at in 2019, what was the mean survival of the centers that offered active treatment, and it was 29%. So we go from what might be considered impossible, kind of this 5 to 6% range, and then 12 years later, we're talking a mean survival is 29%. Now, obviously, we want to do much better than 29%. So this is sort of what we'll talk about is one approach to achieving this, which is what way we've been approaching this at Iowa. And this is looking at the survival of our inborn population. And I would consider, some people consider this peri-viable infants. I would consider them viable from 22 to 24 weeks. And this is cumulative data because the numbers in any one year are very small. And this is from 06 to 2021, so that's 16 cumulative years. And we've always been doing, when we began this, a very proactive approach. So we looked at survival at 22 weeks, 60% out of 74 infants that were live born. 23 weeks was 76%, and 24 weeks was 85%. Now, as a neonatologist, you'd say, well, if the parents don't want resuscitation, do you count those babies? Well, we count all of them because I think it's important not to do what the obstetricians would consider cherry picking. So we look at both numbers. And now, as a neonatologist, you look at what was the survival of babies that we actually did active therapy with was 64%. Only 5 of our patients have not requested resuscitation at 22 weeks. So this was 69 admissions with 44 survivors. Now, another issue is people constantly, that a lot of people just don't want to believe the concept that 22-week babies can survive regardless of where you are in the world. And they think it's a dating issue. And I was complaining to one of my patients' families about this. And the mom says, hey, don't you remember I'm IVF? So I said, oh, okay. She said, put my babies in there. I said, okay. So this was a twin IVF pregnancy. Twin A was born at 22 3/7, 485, 39th percentile. And her sister went 4 more days, became 23 and 0, did a lot of good growth in there, and was almost LGA. She was 87th percentile. And this is them at 15 months. And the interesting thing is that the 22-weeker is doing better than her 23-week sister in terms of growth. And she's got a better attitude. Now, let's look throughout the whole world at survival. And this is looking at basically live born. So at Iowa, we'd be here at 60%. Now, this is Sweden. And at Sweden, this was looking at again, also all live born. This is Cologne, Germany. Now, in Cologne, Germany, this one is, again, looking at all live born. And this is Japan. Now, the Neonatal Research Network published a paper recently in 2022, which has confused a lot of people because depending how you read the paper, you'll go, oh, wait, 22-week survival is 10%. Well, and this, or 11%, and was 11%, including all centers, including all babies, even places that didn't offer active treatment. So if you looked at what was the survival when you actually offered treatment, it was 30%, which is similar to sort of the 27, 29% we talked about with the Neonatal Research Network. And this is the research network here. I'm sorry, this is the Vaughan network right there. And the important thing is everything jumps up dramatically between 22 and 23 weeks. But the important thing is this is replicable, and it's certainly not a biological limitation. Now, there was a recent paper out of Nagano, Japan, published in 2022, very small numbers, 16 babies, and they had 13 out of 16 survive, 81%. And that was over a basically 8-year period of time, so very small numbers. And that's certainly achievable elsewhere. When I look at Iowa, if I decide to, again, pick specific years with small numbers, here's 77% survival, 10 out of 13 in 2016. In 2021, it was 7 out of 9. Now, I would never tell families this type of survival at 22 weeks. We stick with the 60% because the larger number base you have, the more valid that information will be. So the key thing is starting before birth and having the right culture and attitude. So you want to have a proactive approach. So it's a philosophical expectation that infants born at 22 weeks gestation will survive and thrive. This Swedes talk about this also in their literature, that when they have tried to export their concepts, if the country or NICU that's interested in learning doesn't believe any of this, it doesn't work. I would say here is probably, this is one of our smaller survivors, 22 and 2/7 weeks, 335 grams, less than 1 percentile. So SGA 22 and 2/7, and there she is there. It's the understanding that successfully caring for an infant born at 22 weeks gestation is a constantly changing technological and medical challenge rather than a fixed immutable law of nature. Now, I would have told you 33 years ago, in 1990, this was a fixed immutable law of nature. You know, I had 23 and 5/7 week IVF twins. They melted away. Basically, the only surfactant we had back then was Exosurf. They did not get any of those steroids. We didn't have a very good concept of how to minimize volume trauma with high frequency ventilation perfectly. And we didn't have the ability to have inhaled NO to rescue patients who develop pulmonary hypertension acutely. A lot of these issues, now that we have better surfactants, we have antineonatal steroids, we have a very active anti-volume trauma approach and the ability to rescue with inhaled NO, things are very different. It's the realization that a large part of successfully caring for infants born at 22 weeks is having a standardized multidisciplinary culture that supports a team approach to care of these infants both medically and emotionally. So medically, you can't have everyone, you know, I've been places, depending what faculty's on, the baby be started on the jet or the oscillator or SIMV, pressure control, pressure support, or volume ventilation, conventional volume ventilation. So it makes it very confusing. There is no standardized approach, and there's a wide range of things that go wrong. Plus, everyone is not becoming, no one's an expert in any one way. Emotionally, it's pretty critical because even if things are going well and your survival is 60, 70%, well, you have to think about 3 out of 10 babies still die. And if those 3 out of 10 die in 1 week, which has happened to us before, suddenly, even at Iowa, people are like, we don't want to do this anymore. It's emotionally devastating. And so you have to sort of say, hey, we can't focus on the ones who pass away. You need to focus, what about all those babies who lived and are doing well, you know, at home? And so sometimes the team has to be prepared for this and be supportive of each other. People can't walk around, you know, under their breath saying, why are we doing this? We're doing this for the ones who will survive, a chance to survive. Number 4, it's always respecting, supporting the parent's preference, either initiate active treatment or choose comfort care. If the parents say that we're not interested in resuscitation at this gestation, we're okay with that. So there was a set of twins. The first one was born at 22. The parents said, well, we're not interested in resuscitation. We just want to do comfort care. We're like, okay. And then 5 days later, the second twin, they're like, well, we want resuscitation. The steroids have kicked in, and we did. And that baby, he's now 14 years old and runs a podcast. At the same time, there are patients that we know, the mother is in horrendous chorioamnionitis. We know this baby probably will not make it, but the parents want us to try. We'll try, and the baby passes away within less than 24 hours. The parents are still grateful for that 24 hours. And they often come back a year later to visit the hospital. It's a little bit more challenging during the 3 years of the pandemic. It's a mutually supportive interdisciplinary teamwork with the obstetricians begin treatment before birth with the use of antineonatal steroids, even possibly before 22 weeks. Okay.
Sorry, that was my bad random click.
All right. I thought that was the obstetricians breaking in to stop me talking about steroids. But so we do 21 and 5/7. You get sort of max effect at 48 hours, which is why we do 21 and 5/7. And the key is you can't have obstetricians decide that they're going to start giving it at 22 if half the neonatologists refuse to take care of a 22-weeker and half do. So there has to be unity between both services. It also is very, very hard for the neonatologist service to say, well, we're going to start caring for 22 weekers. And the OB is like, well, I'm not giving it until 23 or 24. Well, that's going to be really, really difficult. Now, even giving steroids, even if you're a steroid center, sometimes these babies come in and just deliver. So there's not even time. But our goal is, even if we can get just a couple hours, our OBs will give it. To realize that infants born at 22 weeks are not just smaller versions of infants born at 26 weeks, and to be treated accordingly. Now, they are smaller, so some definitely need access to 2 OET tubes. But you have to adjust differently. You just can't, say that, well, a 26 weeker can be successfully extubated at 5 days of life. When you do that with the 22 and 23 weekers, it usually results in a disastrous outcome. To recognize that the greatest error is not to have tried that and failed, but in the trying, we did not give it our best effort. This is how we got to the moon. We all think that we give it our best effort, but sometimes it's hard. It's very easy to look at a gelatinous baby and say, oh, this is just too hard, titrating everything. Sometimes I think that, but I get over it after a few milliseconds. And then importantly, to understand that 3 sorts of ethical concerns are generally raised with the treatment of babies born so premature. One is that too many survivors will have severe neurocognitive impairment. Another is that the parents do not want such treatment. A third is that it costs too much. Evidence suggests that none of these concerns is valid. And that was an ethical article published in 2021 by Dr. Lantos. So let's talk about the philosophical differences. Are we rising or are we falling? So we look at the New England paper that's sort of started this more nationally, was published in the New England Journal in 2015. And it showed that the rates of active treatment account for 78% of between hospital variation survival among children born at 22 or 23 weeks. Just 22% of those born at 24 weeks. But the rates of active treatment did not account for any of the variation outcomes among those born at 25 or 26 weeks. So yes, you have to decide to treat. But if you just decide to start treating 22 weekers without any plan on how we should approach them differently, it will fail miserably. And that's what often happens suddenly when people want to start doing this without thinking about, we better have a very standardized plan on how we're going to approach this. So differences in hospital rates of active treatment do not account for all variation outcomes. For example, among hospitals that treat 100% of infants born at 24 weeks, rates of risk-adjusted survival vary from 42 to 78%. So this just shows even at 24 weeks, where we don't argue really about peri-viability for the most part, there's a huge difference between centers. So the idea is to try to understand what is, and the differences in management approaches. And let's say, can we learn from each other what management approaches tend to have the best outcome? So factors other than just the decision to resuscitate contribute heavily to the variation outcomes. And importantly, hospitals which active treatment was more often initiated had higher rates of risk-adjusted survival. So as you sort of transfer from 24 to 23 and then 23 to 22, the care of the older patients constantly improves. So to do this, I think it's best to have a small baby system. It doesn't have to be a small baby unit per se, but the idea is that all the small babies should be treated the same regardless of who is on service. So it's a dedicated, integrated structure and culture for extremely premature infants. The system is the star. This is the baby. Here, buried in this population here would be the neonatologists, the neonatology fellows, the nurse practitioners, the nurses, dietitians, respiratory therapists, family members. It's all one big team focused on the baby. So what we have is we have a separate dedicated unit of 14 beds. We can call it our Bay 1. We admit all babies under 29 weeks are admitted here, as well as the most critically ill term infants. So basically, we consider it a neonatal critical care unit. The reason that we admit most critically ill term infants, as well as the extreme premature infants, because we want the nursing staff to maintain their excellence, expertise of critically ill infants, regardless of gestational age or size. Now, the 28 and 6/7 weeker might stay there 4 hours. The 22 weeker might stay in that unit 8 weeks. So obviously there's not a set time. You move out based on stability. We pretty much have a separate nursing staff that has generated a huge amount of expertise, which is pretty critical. We have a separate location, which is right next to labor and delivery. So most of the 22 weekers are already on the jet ventilator before 10 minutes of life. We have a separate critical care lab for our entire NICU, so we can get labs back within 5 minutes. And to me, one of the most important things also is having a separate medical team for just these 12 to 13 patients, because rounding on 12 to 13 highly critical infants takes just as long as rounding on 24 level 3 type patients or 36, step down patients. So the idea is you want to have that time focused so you can fine tune electrolytes and blood pressure, ventilator settings, and so forth. We have a separate attending service, you can say quote unquote neonatal intensivists, so that everyone doesn't really attend in that unit. If someone that feels like, gee, I don't have the energy anymore after 40 years, you don't have to, be in there. If someone just feels uncomfortable, they'd rather do the level 3, it's okay. So about a quarter of the faculty don't attend there. So the idea is you want to be there. You want this level of intensity. You want this level of having to do a lot of multiple decisions on multiple patients simultaneously. There's always a fellow, there's always nurse practitioners, residents, always dietitians, pharmacists, respiratory therapists for that area. So for our unit, what I'm showing here is this is the part of the area of the unit. We have a total of 84 rooms with 88 beds, and this has been expanded. So now there's basically 14 beds over here. The important thing is the babies are being delivered over here and brought through, like I said, and get on first intention high frequency right away. Here's another 22-week, 2nd percentile, 395 grams. Okay, so management begins before birth. And this is, I would say, most critical is the antenatal steroids. You've got to have the maternal fetal medicine service needs to be on board. Looking at the data, antenatal steroids at 22 to 25 weeks reduces death, severe IVH, and the incidence of neurodevelopmental impairment at 18 to 22 months. And importantly, significantly increases survival at 22 and 23 weeks gestation. This paper here that was published in Bonn, from Bonn data in 2018, doubled survival 18 to 39% at 22 weeks. And the NRN paper published in 2022 didn't separate this group out, but they combined this group together and it went from 36% to 54%. And there are numerous other papers that have been published over the time looking at outcomes with antenatal corticosteroids. Now, if everyone knows that antenatal steroid therapy at greater or equal to 24 weeks improves lung maturity and reduces RDS, NEC, zero IVH mortality, so we all use that. And what's interesting, we don't. As a specialty group. So looking at here, this is all VLBWs, 22 to 33 weeks, data from the Vine network, from 06 to 2021. You can see Iowa, one of the things is our OBs have been very good about giving antenatal steroids. We're always hovering around 95%. And you can see the Vine network used to be in the 80s and it's taken a long time and they've gotten themselves up to 90s. So the more we can get antenatal steroids on board, the better the outcomes. If we look at in 2021, I think we barely missed only a few patients, so 98.5% antenatal steroids, and the typical level 3-4 center type C was 89%. Now, if we look at infants delivered at 22 to 23 weeks gestation, our antenatal steroid use was 91% in the Iowa inborn cohort. And we published that in 2020. Now, an important thing that's helped dramatically improve the chance of survival and improve neurodevelopment outcome is that ACOG updated their guidance, and this was in September of 2021, antenatal corticosteroids. So prior to September 2021, at 22 and 0.7 to 22 and 6/7, this used to say not recommended. And they changed it finally to consider. Now, not recommended doesn't mean it's harmful. They just feel there's just not enough evidence for them to say consider. And the only way you can get recommended, there has to be large randomized controlled trial. There's just no one really enrolled any 22-weekers in any of these trials. And there's not enough of them. In the US, it's only about 1,700 of them a year. So it's just not going to happen. And so they put the consider. And the whole point of saying consider is that there has to be, it doesn't make sense for you as the OB to give it if the NICU doesn't have an approach to caring for these patients or refuses to care for them. So to me, this was a huge breakthrough. This, in the previous 8 years talking about this, the biggest problem I always had was convincing people to give steroids prior to 23 weeks. Now, like I said, we started 21 and 5/7 because we want the steroids full effect by 22 and 0. Let's look at some other characteristics of our inborn cohort. What I've always been told is that our patients are all Scandinavian farm babies, and our 22-weekers deliver in the cornfields of Iowa. They suckle on the pigs, and they don't need any care, and that's why they do so good. And that's really, I would say, not completely true. Yes, there is more white patients here. It's 78%, and then there's black, 18%. And 23 weeks, it's 67%, 24, 67% white. So yes, that part is true. But if we look at survival of 22-weekers, you can actually see here black survival 62% and whites 59%. So we don't see any continent of origin difference. Obviously, males are an inferior species. So male survival at 22 weeks was 56% and female 65%. But it's not so dramatically different that you'd say, well, gee, I'm only going to offer survival to females. Now, C-section, only 8% of the 22-weekers are born by C-section. We do not routinely do C-sections at 22 weeks. We don't do fetal monitoring at 22 weeks. That monitoring starts at 23 and 0. Now, the C-sections have all been done since 2016. And there was 12%, so 6 out of those 48 babies since 2016, or 8% since we've started. And it's for maternal indications only. So these 6 mothers, this pregnancy had to end for them, the mother's life to be saved. And these mothers requested, I would like you to do C-section, and that was the only choice because the babies with the fetuses would not have survived the inductions. And these are usually for high blood pressure. Now, if you look at Sweden, they don't do any C-sections. It's 0% in this publication from 2021 in the cohort for Sweden. So the interesting thing is that the C-section rate, if you look at the whole US VON network, that a lot of centers do C-section. There was 32% C-section rate at 22 weeks if antenatal steroids were given. So yes, there is, this is controversial. The question is, if you give steroids, does that mean you have to do a C-section? We say no. We don't feel like there's any direct linkage saying because you give someone steroids, you have to do a C-section and have to do fetal monitoring. Because the problem is, as a high-risk obstetrician, you're dealing with 2 patients, and they've got to balance a huge number of risks. So we have complete equipoise with this. We defer to the obstetricians. So we don't do, like I said, fetal monitoring in 23 and 0, and that's when you can see the C-section rate jumps up. It's 44% at 23 weeks and 71% at 24 weeks, because now you're starting to section for fetal distress. Multiples occur quite frequently at 22 weeks, and because while you're delivering early, while you're going to preterm labor, it's multiples. And you can see it drops off 23 to 24% and 24 to 13%. The other main issue is chorioamnionitis. So 30% of these 22-week deliveries, chorioamnionitis was present, and that's something that we need to think about. And there really wasn't an issue with maternal hypertension. Okay, so now let's talk about the delivery room approach. So this also needs to be standardized, and you have to think about it very differently because you're not really dealing with any reality alveoli at all. So you have infants that are born at 22 to 23 weeks gestation. We initiate resuscitation with 50% oxygen, not the 30% talked about with NRP, and obviously not room air like a term baby. And you titrate goals to minimize hypoxia and hyperoxia. So looking at the literature, there was this interesting paper that was published in 2017. And if you look at the subgroup under 28 weeks, when they were resuscitated with room air, mortality was 22% versus 6% with 100% oxygen. So that's almost a 4-fold difference, just how you approach these infants right in the beginning. And now, I'm not saying to use 100% oxygen, because really we titrate to goals, and we really had no issues since we started with 50%. And the key is, we were trying to give enough oxygen to get here. By 5 minutes of life, you want to be in the 80s. And what's interesting, another article was published in 2021 that showed if you don't reach greater or equal to 80% by 5 minutes, it's associated with a greater risk of death or major neurodevelopmental disability. So I can tell you, most of the time, with starting with 50%, most of these babies actually end up weaning on their oxygen, coming down. But what you don't want to do is get behind, because a lot of the reasons they're being born early, we talked about the chorioamnionitis, they can have pulmonary hypertension, and the pulmonary vascular resistance doesn't drop, and you end up then, dying pretty quickly. I know there's eventually going to be a RCT at some point for the next 5-10 years with a sort of a 67 trial of 100% in a tiny population. And I would think before I start with 100%, I would wait for that, but I would say 50% is certainly valid. The next thing is, for this population, you should have access to 2O tubes. So Sweden, Japan, and ourselves, we all initially intubate 22-weekers with 2O tubes. If we looked before we made it a standard, it was already happening. 93% of 22-weekers were intubated with a 2O tube, and 41%, usually the SGA babies at 23 weeks, were intubated. The next thing to think about is ET tube depth. You can't use weight in kilos plus 6 centimeters. You'll be right main stem. So with these smaller babies, you have to be more like 5.5 to 6 centimeters at the lip. Now, a very interesting thing was just published in 2022 out of Alabama, and they were looking at invasive compared to non-invasive respiratory support. Because obviously, if it's a 26-weeker, we really want to avoid intubating. And if they don't need to be intubated and they're active and vigorous and they can be on non-invasive, that's great. Well, so they were trying to practice that same way at 22 and 23 weeks, and it failed miserably. If you actively intubate them right away, it reduces severe IVH and death by over 2-fold. So trying to avoid intubation in a 22 and 23 weeker doesn't help. You're just going to increase your severe IVH rate and increase your mortality. And that was published in 2022. Now, again, I talked about the importance of, you can't use weight in kilos plus 6 centimeters or you get right main stem. So they'll come to the NICU. We resuscitate with general bagging by an ET tube. We use a PEEPA 5. I'll talk more about that because you want to avoid hyperinflation. We start within 10 minutes of life on first intention jet. And once we get the initial chest radiograph, we'll give surfactant within 10 minutes. The times that the fellows constantly tell me, well, I'm so good, I'm not going to need an x-ray. And then they go and give the surfactant. I'm like, well, yeah, you're so good. Now we have a lot of problems because half the lung is missing surfactant. So it's such millimeter differences. It's important to have the x-ray confirmation before giving that surfactant. We also want to minimize hypothermia during resuscitation. We use polyethylene blankets and hats, and that we get the delivery rooms up to 25 Celsius. And importantly, we have them on a transwarmer mattress for resuscitation and for transport back. Once we put them under radiant warmers, once they're under that, we'll remove the transwarmer mattress because you don't want them to get hyperthermic. Okay, so 2O tubes, we published on that in 2022. People always thought if you need a 2O tube, it doesn't work, and that's certainly with the jet, it works just fine. The smallest patient we had with our 2O tube was 279 grams, and the smallest patient that we had with the 2.5 was 463. Now, 2O ET tubes do require higher jet PIP because we know resistance goes up to the radius of the 4th power, but that's to deliver the same tidal volume. So yes, you'll need peak pressures in the high 20s versus the low 20s, but the CO2 would be exactly the same. And obviously the 2O tubes are in more premature babies, so it's more likely they need to be upsized. Half of them got upsized versus only 12% with 2.5 group. But most of the upsizing was usually around the same time, around 4 weeks of life. So the main point is that there was no difficulty in maintaining effective ventilation oxygen with a 2O tube on the jet. Obviously, you need to have the 2.5 adapter into the 2O tube. And importantly, survival was 77%. So this concept of a 2O tube is not a marker of viability. After we published that, some other people sent a letter in saying that, yeah, Sweden and Japan and Cologne, Germany, you can also have successful ventilation with conventional and other modes of high frequency with 2O tubes. You want to have standardization of care. So golden hour protocol. What matters is not what's really on this, but it's the same goals. You know, we want the babies not hypothermic. We want surfactant given. We want dextrose started. We want antibiotics started. Because like I said, 30% of these patients, chorioamnionitis is present. You cannot get behind if they're infected. And obviously keep the mother in line with everything, up to date with everything that's going on. We have standardization of care. We have computerized physician order entry. Now, this isn't perfect because if someone decides to, you know, you say to use the order set and next thing you know, someone's just typing in what they want. So it works when people use it. We standardize certain things that we feel all these babies should get. Obviously, one is caffeine. This is brilliant work by Barbara Schmidt showing significantly reduces BPD. So we give it all patients under 1,250 grams. We try to give in that within the first 24 hours of life. We're still vitamin A center where we can get it. And that's based on this multi-center RCT by John Tyson. Those are already pre-built in there. We also have paper guidelines. Paper doesn't crash. And these guidelines help to standardize our approach. They give initial fluids and transfusion guidelines, phototherapy guidelines, ventilation goals, respiratory settings, outcome data for counseling, feeding guidelines so we don't push feeds too aggressively, and medication guidelines. This is an example of what it looks like. The last one I created was in 2020. The 2023 version hopefully will be done in the next month or two. But so this is just, as you can see, we're all transfusing at the same level. We're all kind of starting the initial fluids. We all start phototherapies at the same level. We all give the same survival statistics and morbidity statistics. We all take our time with the feeds. So let's talk a little bit about peri-viability. So how is it possible to survive without a VLI? Because, you know, the velar sacs theoretically don't really develop to 27 weeks. Well, terminal bronchioles are branching to respiratory bronchioles during the canalicular phase, and some now also branch to alveolar ducts, which some will terminate at the tip into a velar sac. Once you have the alveolar sac, which is thin wall and vascularized, normally begins at 24 to 27 weeks. You can exchange gas. And importantly, cranial segments mature faster than caudal segments. So you can have a few areas of the lung that are mature enough to survive even at 22 weeks gestation if you minimize damage to the lung. So the idea is that the entire lung does not develop in a homogeneous fashion. There's a lot of heterogeneity, which is what allows this survival to occur. So you have some alveolar sacs present at this canalicular stage. Now, you need two important things. You need the antenatal steroids. They'll accelerate lung maturation. They stimulate differentiation of alveolar type 1 cell, which allows gas exchange, and type 2 cells for making surfactant. Extremely important, it thins the mesenchyme for gas exchange and increases evasion of the capillaries in the air spaces for oxygen transfer. So in the biological threshold days in the late 80s, early 90s, we would have patients that we could ventilate, but we could not oxygenate because CO2 diffuses 20 times more efficaciously through mesenchymal tissue. And that was the biological threshold. We couldn't oxygenate, but we could ventilate. With the antenatal steroids, now we can oxygenate. And importantly, you have to have a lung protective strategy to minimize volume trauma, because once you get the mechanical injury, which can occur very quickly, it makes it very hard to survive. So you want to have standardization of care. We base it kind of on a developmental pathophysiology framework. We want a lung protective strategy to reduce the risk of PIE, which is really the main problem, and obviously pneumothorax at this canalicular stage of lung development and we use high frequency. So as you can see, the canalicular stage kind of begins at 16 and can kind of extend obviously through 25 weeks. And some of this saccular stage does get into here, primarily in the cranial segments of the lungs. So it's so important if you're dealing with the canalicular stage to avoid shear force injury, the valvular trauma. And the shear force at canalicular stage is the PIE. And that's what people get into trouble with. So we're first intention. We use first intention jet ventilation for all infants born at 22 to 26 weeks who require mechanical ventilation. This 26 weeker or even the 24 weeker, occasionally there's a 24 weeker that comes out screaming. It's like, well, we're not going to intubate him. We'll just try him on non-invasive support. And if he fails, he fails. But we don't do that with 22 and 23 weekers. They get intubated, so we don't right away. Okay. So why is PIE prevention so important? So PIE, and this is an example here of a patient transferred to us that passed away from PIE, is a collection of gases outside the conducting and gas exchanging airways, which obstructs both pulmonary blood flow and ventilation, and often develops within 48 hours of life. And you can see here, this basically had no cardiac output. So came to us at a couple of days of life with no urine output for days. And despite, we fixed the PIE, but eventually withdrew support because without cardiac output, there was severe cystic brain injury. And unfortunately, that was, the other two of the triplets died at the outside hospital. And by the time they sent this one, unfortunately, the brain injury was severe. So this is bad when you have a compressed heart. PIE has high mortality and morbidity associated with the earlier the chronological age, the lower the birth weight, and the lower gestational age. And this is one of the papers that stimulated the concept of low tidal volume ventilation with high frequency, was the horrendous death rate from PIE in the 80s. In the pre-surfactant era, mortality was more than 60% if your PIP reached greater than 25 at any time during the first 2 weeks of life for babies under 1,500 grams. And this is why if you're using conventional ventilation, people go like, oh, well, it's volume guarantee, blah, blah, blah. Well, if you don't reach the volume, it keeps alarming, you go up on the pressure, and eventually you're going to hit 25 potentially on some of these patients and end up developing a lot of bad issues. So with the jet, you want to take an anti-valvular trauma approach, and that's why we use it. We know, if you look at the research, jet ventilation increases healing of PIE, it reduces incidence of air leaks, and improves survival of neonates with pneumothorax and PIE. So that's why it got approved in the US in 1989. And then once it was approved, Dr. Martin Kessler did a RCT looking at treating infants with RDS with surfactant with first intention jet, and it reduced the incidence of BPD. So to me, there was clear evidence, and we said we should be first intention high frequency center, and that was back in the 90s. Now, why is high frequency ventilation so controversial? And the real issue, it's the carburetor, not the hammer. Although the tools we use to support gas exchange are important, so are the expertise and training of the carpenters that use them. Without evidence-based physiologic targeted strategies, our tools for supporting gas exchange can promote injury instead of improving the quality of lives we save. This was a paper from '97 from Reese Clark. So a ventilator is not the same as giving a drug. Giving a drug, if we know the correct dose and we know the correct interval and we know the bioavailability, we can use it intravenously or orally. But if you have a drug that no one tells you that is zero bioavailability orally, and you give it orally and you go, oh, this drug doesn't work, and another center gives it IV and it works all the time. It's a simplistic way to look at it, but if you don't use the ventilators correctly with the proper strategy, they're going to cause a lot of harm, and that's created the controversy. So let's look at the controversy here with the jet. There were two major RCTs of first intention use in the surfactant therapy era. These were both done in the early 90s and published in the middle 90s. The one in 96 was by Dr. Wiswell, and he said the jet did not reduce the incidence of BPD, and unfortunately, it increased the incidence of cystic PVL. Now, did the jet do that? No, the management did that. So the problem was extreme hypocarbia. The mean CO2 level was 17. Basically, you have minimal cerebral blood flow at that point. Now, they also limited the PEEP to 4 to 5, and it wasn't the PEEP of 4 or 5 that caused this. What caused it was, in order to increase mean airway pressure, their only choice was to increase the PIP, because they didn't allow people to increase the PEEP. and the PEEP was not adjusted to either limit tidal volume or to maintain or increase mean area pressure, which thus was dependent on PIP. So if your mean area pressure is dependent upon a high peak inspiratory pressure to oxygenate, well, you have an alarm going off continuously, which is your oximeter. So in order to tolerate that, people started tolerating low CO2s. That's just human nature because they had no other choice. Now, and that was a problem with the management strategy. In contrast, at the same time, in Martin Kessler's paper and study in 97, the jet cut the incidence of BPD in half from 40%, I think, to 20% in this population. No difference in PVL or IVH. And their key was an optimal mean area pressure and tidal volume strategy. So the PEEP was adjusted. They tended to use 7 to 9. There was no hypocarbia. Their mean CO2 level was 40. But importantly, the PEEP was adjusted as needed when the PIP was weaned to avoid excessive loss of mean area pressure. So, the CO2 is under 40, then what you do is you lower your peak pressure and raise your PEEP to keep your mean area pressure adequate. So you avoid the loss of oxygenation. So there was no need to tolerate hypocarbia to maintain mean area pressure. Now, this doesn't mean you should start at a PEEP of 7. This was in the early 90s. Most of these patients were not getting any of those steroids. The surfactants were not very good. And so, when I tell people starting at 5 to avoid hyperinflation, they keep quoting this old article and I say, well, that's a different era. And the danger is you start some of these babies on 7, you can be hyperinflated and get into trouble right away. So you don't need to, the idea is to feel free to just the PEEP based on the response to surfactant. Okay, now the other thing that we figured out over time, since we've been using first intention jet since about 06, is the jet rate. So we found over time that you really have to avoid air trapping because you have passive elastic recoil. So you look at the gestational age, so under 24 weeks, you want to start with 300 breaths per minute, which is an IU ratio of 1 to 9. What had happened is, in the past, when we first started at 420, then we'd see a little bit of PIE, we dropped to 360. Then we started 360 as we went younger and younger, and then we see a little bit of PIE and we dropped to 300. And finally, my colleague said, hey, for the really tiny babies, can we just start at 300 and avoid it in the first place? I'm like, that's a great idea. Let's just do that. And it really become kind of a non-issue. So with the jet, with a lower rate, 300 breaths per minute, more time is spent in exhalation with a fixed I time, the 20 milliseconds, which decreases air trapping from passive elastic recoil. So that's the first thing. You've got to avoid that air trapping. So this is one major breakthrough. But you don't stay at 300 for the baby's entire stay on the jet. You need to change the rate as the lung development proceeds. So the jet rate can be increased as needed after a few weeks as the lung develops to improve both ventilation and oxygenation. So a better way to improve both ventilation and oxygenation rather than just cranking the peak pressure up and cranking the PEEP up is to change the baseline rate as that lung goes from canalicular to more and more of a alveolar saccular stage. So it sort of mimics the 24 to 26 weeker and then the 27 weeker as the lung develops. And the lung development continues, obviously, ex utero. If PIE does develop or pneumothorax drop to a lower rate, and we always leave our I time at 20 milliseconds for first intention because our goal is to minimize our tidal volumes. So the goal of the initial rate of 300 breaths per minute avoids air trapping, plenty of time for gas escape, especially when you have a 2.0 tube because there's higher resistance to flow. You want to avoid hyperinflation, you want to avoid overdistension, and importantly, hypocarbia. Now, pressure. You do not want to see this. So there are centers that get fixated on starting too high a PEEP right away. Most of these, our surfactants are much, much better than they were in the early 90s when we were talking about ExoSurf compared to CureSurf or InfoSurf. And they kept starting at 7, 8, or 9, and things were over right away. We also know from the SAIL trial, which had to be stopped early because of a 500% increase in mortality for babies under 26 weeks, that if you use sustained airway inflation of high PEEP for a long time, you increase mortality 500%. So you have to be very gentle in this population. So the initial PEEP that we would use, the goal is to avoid mechanical injury from hyperinflation, lung protective strategy. But a lung protective strategy in this case also is neuroprotected because it avoids impeding venous return. You don't want to be pushing blood into the brain and not allowing to escape. You have a greater risk of IVH. You don't want to have poor cardiac output for the brain. You have greater risk of ischemic brain injury. So neuroprotection must supersede lung protection. In this case, they both work together. So, we've started 5 and the steroid improved surfactant era. And then, will we stay at 5? No, we'll adjust it based on the response to surfactant and the findings on the x-ray. So we might range from 3 to 14, 10's more likely, it's more like 4 to 10, even 4 to 9. We just PEEP as needed based on appropriate aeration and inflation, 9 ribs, and balance oxygen toxicity versus risk of mechanical injury. I get worried when we're down to 21% and people are getting to 10 ribs. I'd much rather be at 8, 9 and on 35% oxygen. So I know if you're at 9, 10 and down to 21%, it's not going to hold very long. And then 12 hours later, you get horrendous PIE, which is very hard to heal up. And we know the PEEP is generated by the inline conventional ventilator. And we use the measured value on the jet because I want to know what the baby's receiving. I don't get too concerned about what the machine is reading. I want to know what the jet is reading versus what the conventional ventilator is at. Peak pressure, we talk about starting in the low 20s, but you have to think if I have a 202, we're probably going to have to start in the middle 20s based on what we've shown. You want to see good chest wall shake. Well, titrated based on CO2. And usually it tends to be less than 35. And always remember the delta P is proportional to the tidal volume. So the settings for side breaths on the conventional ventilator. On first intention, you don't need to have any size to start with. Your recruitment is going to be the surfactant you're giving. So you're recruiting with surfactant. The babies are not born with a side deficiency, they're born with a surfactant deficiency. So you're going to be bagging in your surfactant, and that's going to do your recruitment. We start size after the babies are now transitioning, and it's not so much surfactant deficiency disease anymore. It's really a deficiency of the stability of the rib cage, weakness of respiratory muscles, and you start to develop atelectasis, and we call this patchy or wandering atelectasis. It often tends to be right-sided because we tend to put the babies, even though we think we're rotating them equally, they tend to spend more time on the right, plus the right takeoff's a little bit higher up. So if we're treating this patchy atelectasis, we use a rate of 4, I time 0.4, the peak pressure, PEEP plus 6 to 10. The peak pressure on the conventional setting has to be enough to be above 3 cc's per kilo, because you got to get above dead space. And the way you know that is when that side breath goes, you must see chest wall movement. If you're not seeing chest wall movement, it's not enough. And this is again for alveolar recruitment for patchy or wandering atelectasis. Importantly, you continue once started. The baby's respiratory musculature doesn't get better in 4 hours. The rib cage doesn't calcify perfectly in 4 hours. So a lot of times you don't use it. It's not a recruitment maneuver and you stop it. You do that with an adult with a normal rib cage and normal surfactant and normal respiratory muscles. For these babies, they do a lot of positioning and the dependent site gets collapsed. They need the positioning so that they can develop appropriately. So leave it on. And the same, Dr. Kessler also does the same thing. However, he likes the rate of 3. Now, the other thing we use it for, as the babies get better and better, but their lungs they're not robust enough to be extubated yet because their brainstem hasn't caught up, so they're having increasing spells. And the spells start to manifest them as the lung disease gets less, you're not giving them as much jet support. So you start having spells. And these spells are these desaturation spells. And I call them central apnea type spells. These are alveolar hypoventilation spells, which present with significant desats, less than 70 to 80, when the respiratory rate drops below 15 to 20. So for these babies, they don't have to be apneic for 20 seconds. They have no FRC. So if they just drop the respiratory rate, here's an example here, into the 20s, you can see the desaturation spell that occurs. So this is where you're not using the side breath to ventilate them. You're using it to flush oxygen. That's why you need to be above the dead space into the system. And so in these cases, the rate needs to be much higher. So a rate of 4 is good for atelectasis, but 10 times you need rates 6, 8, 10, 12 for these central apnea type spells to avoid these severe desaturation spells. And these are ones where people suddenly will give up on the jet and want to put them on conventional, but then in conventional, in order to ventilate, you're using 5 to 6 per kilo rather than 0.5 per kilo. Obviously, if pneumothorax develops, you're back down to rate of 0. Okay, so you want standardized ventilator goals. So we want rigid adherence to the goals to avoid fluctuations in cerebral blood flow. This is a neuroprotective focus. This is not the first week of life is not the time to tolerate CO2s in the 65 to 80 range to be lung protective. These aren't 36-week post-menstrual age, severe BPD babies trached on a ventilator type of thing. These are very high risk of lung injury, but more importantly, a very high risk of brain injury. And the lungs can heal, but the brain is not going to. So you've got to protect that brain from cerebral ischemia or excess cerebral blood flow leading to IVH. So we'll target 45 to 55. We maybe find sort of kind of 40 to high 50s the first 3 days. We kind of go a little bit wider the next 4 days. So the first week we're trying to stay kind of in the 40s and 50s. This means we might get gases every 3 to 6 hours in the first days. If we have a line, we'll get it every 3 hours. If we don't have a line, we might be heel sticking every 6 hours. This is a really important period of time. This is when you're protecting the brain. So we're getting labs, even heel stick every 6 hours to look not just at gas, but glucose and sodiums and so forth. Now, oxygen saturation, we try to avoid alarm fatigue. And we have saturations that are based on post-menstrual age, which helps to do 2 things. One, it helps to avoid severe RRP, as we know about the support trial. And as the babies mature and ischemia can become more of an issue, it avoids ischemic brain injury and ischemic gut injury. So this adapts. Another thing is, if we have post-surfactant slump, we'll treat it with repeat surfactant therapy. So post-surfactant slump is a lack of endogenous surfactant production. And 20% of infants under 1,000 grams can develop this after day of life 6. And more than 70% of the infants who have it have an improvement in the severity of the respiratory disease with treatment. So this is looking at post-surfactant slump. This would be babies who don't have RDS, just intubated because of apnea. These are patients with RDS, and you can see by day 7, they go into 2 groups. One slumps, and they rapidly get worse in the severity of the lung disease. And the other one kind of putters along and getting extubated as time goes by. The post-surfactant slump group often proceeds to respiratory failure and death. And then we looked at the median time for repeat surfactant, which is around 11 days of life, and it stabilizes this process. Now you can predict this is going to occur because if you need 2 or more doses, it's a 2-fold increased risk of needing post-surfactants, having the slump. And again, antinatal steroids reduces the risk by 80% of developing it. And either calfactin or poractin treats post-surfactant slump. Now, something else happens in the same time period, which is you might have a hemodynamically significant PDA. So you have to make sure, are you slumping because of pulmonary recirculation? Well, we need to treat that, but you could treat that and you can still be slumping, and you might need to treat both. Also, are they slumping because you're developing sepsis or pneumonia? Or did you overwean the patient and now they have severe atelectasis trauma leading to surfactant dysfunction? So that's one of the things you have to think about. And many times, you send this X-ray and if the radiologist doesn't know how old the patient is, they'll go, oh, newborn, new premature baby with RDS, because it will look the same, the reticular granular pattern. Okay, now extubation. This has to be different in this population. So you want to minimize the risk of atelectasis trauma and apnea leading to failure. So if you look at some of the studies, failed extubation, even for the more mature 24 to 26 week premature infants, this is from a follow-up with a support study, is associated with poor outcomes. And this is a study from 2017. So if you fail in the first 2 weeks of life, and the failure rate, where kids less than 26 weeks, is significantly associated with increased death before discharge, almost 5-fold. So we control elective extubations, as well as increased incidence of BPD, late onset sepsis, and severe IVH. And this is controlled, adjusted for multiple variables. So even though this study didn't even have any 22 and 23 weekers, clearly the ones that were failing were the 24 and 25 weekers for them, 25 and a half weekers for the most part. So this is just not the population to push. And then another study looked at the same thing. And this was not first 2 weeks, this was first 12 days. And again, the failure rate were kids less than 26 weeks. The significant setback in respiratory status, and everything was much worse. And even 72 hours later, it still was much worse. So failure leads to atelectatic trauma, and reinflation leads to a lot of shear force injury. Now, another even more recent study, which is the APEX cohort, and there were no 22 weekers even included in this, but at least they had 23 weekers. And they looked at a different time period, which is early failure. Again, if you can successfully extubate with a bigger baby, that's great. That's what, but if you try to push a baby who's going to have a high failure rate, the ones that failed early had a significantly greater risk of death. And again, it had the same mystical kind of 26 weeks, 25.8, 25.5, 26.3. So these less than 26 week patients are really, you shouldn't really be pushing them off aggressively. This study didn't even have any 22 weekers, and 100% of the 23 weekers failed. So we never push any of our 22 and 23 weekers off in the first 2 weeks, because if they fail, death goes up, severe IVH goes up. You don't want to be pushing them. So you want to minimize multiple failure attempts, especially in the first weeks of life in this population. You want to extubate when ready to have a sustainable respiratory drive. A lot of the failures tend to be they have no central drive, so you don't push them off. And obviously, we extubate everyone to non-invasive ventilation. Since we use NAVA, we'd like most of the 22 and 23 weekers to at least have doubled their birth weight, because you really need to focus on growth for good outcomes. Okay, so the goal of first intention jet is to avoid lethal BPD, which is grade 3A. People don't talk about this is death from respiratory failure, and only a few studies have ever even talked about that. And minimize grade 3 BPD, which is Eric Jensen's much better definition created in 2019, which is invasive respiratory support at 36 weeks PMA. If you have grade 3, which is you're still on the vent at 36 weeks, it's strongly associated with twofold higher rate of late death, serious respiratory morbidity, and moderate to severe NDI among infants receiving invasive rather than non-invasive positive pressure. So this is really the much better classification for BPD in this population. He benchmarked it in terms of serious respiratory morbidity, and using 2018 VON data, if you're still on the vent at 36 weeks, 18% required trach versus only 0.8% with grade 1 or 2. So grade 1 is cannula less than or equal to 2 liters. Grade 2 is high flow cannula or CPAP or NIPPV, and grade 3 is invasive. So I think it's important for people, for infants born at the canalicular stage of lung development, focus on 21st century clinical definition of BPD, which is Jensen's work, invasive mechanical ventilation, instead of the 20th century definition, supplemental oxygen at 36 weeks, because almost all 22 weekers still don't have enough of VLI yet. And they're going to need some oxygen, and that's really not that big of a deal. But if you focus on doing things that you do for 27 weekers to avoid that, you're going to end up having these babies not survive. So let's look at respiratory outcomes for infants born at 22 to 23 weeks treated with first intention high frequency. In this paper published in 2020, there were 70 inborn treated with first intention high frequency. Most are on the jet. This is smaller cohorts. The survival was 70% at 22, 82% at 23 weeks. Median duration of ventilation, 63 days. And you go, well, that seems really long. Well, interquartile is 47 to 78. But importantly, the median post-menstrual age at time of extubation was 31 weeks. So half the babies were extubated by 31 weeks, 75, a quarter by 29 weeks, and 75% by 33. Now, this 31 weeks post-menstrual age is an interesting number because it's not any different than the APEX cohort. The APEX cohort, 31 weeks post-menstrual age, was the same as the APEX cohort of 31.3 weeks. For infants extubated at more than 35 days of life, they had, again, no 22 weekers. And the median gestation age in that cohort was 24, and ours was 23. So I think this is a very valid approach. If we look at grade 3, which is the one that really is impactful, it was 6% from 06 to 2015. It is higher in the last 77, 22, and 23 weekers, 11%, but we've been getting a lot more babies transferred, moms transferred to us who've ruptured before 20 weeks gestation, so a lot more pulmonary hypoplasia. Well, what is the trach rate? I mean, people think, well, you know, I guess you're traching all these 22 and 23 weekers. No, it's been 3. So they're trach babies. We've only had 3 out of 184 infants. 2% have, less than 2% were trached. Some do need supplemental oxygen. It's about 17%, 18 to 22 months, because we basically have no BLI. This is another 22-6 week male, so it's 29 percentile. His twin did pass away. This is him in the mountains. So thinking about global ventilator approaches, kind of looking at, you know, what's consistent among US, Sweden, Japan. You know, we all follow CO2 levels closely to avoid fluctuations in cerebral blood flow. We always use a proactive low tidal volume strategies, whether it's jet, oscillatory ventilation, or low tidal volume targeted conventional devices, which is Sweden does, but they do very early rescue with high frequency being available. So if the pressure goes up and they have to do anything to change the tidal volume much above 4.5 per kilo, they will switch. All use 2O tubes, all work aggressively to avoid overextension, all focus heavily on avoiding PIE. No one's pushing these little babies off quickly, and try to avoid random variation in respiratory management styles. And we tend to all do oxygen targets based on postmenstrual age. Okay, now all the other things, I'll try to get all this together. One is gut protective strategies. So you've got to minimize the incidence of SIP or FIP and NEC. Prophylactic indomethacin should be avoided. There's a 5% incidence of SIP with early indomethacin alone. Combining it with steroids, it goes to 19%. That's with Dex. Combining it with hydrocortisone increases 9-fold. So if you're you really want to avoid prophylactic indomethacin. And this is a paper in 2021 from Nationwide that showed no benefit of prophylactic indomethacin. Another paper's come out recently from the network, really showing no benefit in terms of IVH and increased risk at SIP. There is obviously a benefit in potentially less PDA issues, but that's not outweighed by the SIP, and maybe a little bit less BPD, but again, that's not outweighed by having a SIP. So we always avoid the combination of steroids and indomethacin. In terms of PDA, we use a targeted approach. So I'll talk a little bit more about that later. We want to minimize neck and focal intestinal perforation. We do early trophic feeds within ideally breast milk within 24 to 36 hours, but we go very slowly. Sometimes even only 6 to 10 per kilo, and only if tolerating, and only if they're stooling. If we don't see that, we're not going to push them. We're gut priming. We don't want to push these very immature guts that don't have normal motility. We go to bolus feeds if we're giving more than 4 mLs, so we don't overload them. We use probiotics, and we're very aggressive about looking for meconium obstruction of prematurity or inspissated meconium to avoid meconium-related ileus or intestinal injury, which leads to focal intestinal perforation. So we'll use some glycerins, and if we're not seeing a normal stooling pattern and we're still stuck with meconium stools, between 7 and 14 days, we will do a contrast enema to make sure we remove any inspissated meconium. You can see the overall neck rates for the whole population of VLBWs is quite low. NVN strategies, we want to minimize hyperglycemia and hyperlipidemia. So we try to keep glucoses 50 to 150. We want to avoid dehydration or fluid overload. So we're keeping sodiums 135 to 150. Now, this requires frequent labs, as I talked about. We don't use humidity. There's something wrong with humidity, but we're just not a humidity center. This means occasionally, we might start at 150, and occasionally we might go 200, 250, 300, occasionally 350 briefly. The advantage of requiring more fluids is we can always use 3 fluids without getting fluid overloaded, because it's just evaporating in the atmosphere. So we have UAC fluid with acetate without dextrose to help with fluid management. We have no limitations on our NVN, so it's easy for us to get up to 80 to 100 per kilo per day. So we can easily get our 4 grams of protein in, plenty of calcium, and plenty of phosphorus to avoid refeeding syndrome. And we just Y in some carrier fluid of D2.5. And we adjust it based on glucose needs. Study out of Sweden showed that, in our case, ambient or minimum humidification, it will accelerate keratinization and gets that skin away from being gelatinous. We follow fluids closely. The other unusual thing is these babies may only need a GR, of less than 4. So if you start at, 3.5 to 4 and they start glucose is rising, you need to cut back. They're just not consuming that much carbohydrate. But what they need is protein. And we buffer with sodium and, if necessary, potassium acetate for renal losses, so we don't have to aggressively ventilate. Now, intralipids, this actually has an RCT. So there's an RCT that was done in the 90s that showed starting intralipids 1.5 grams per kilo at less than 12 hours life doubled mortality. So intralipids, the whole point of the study was maybe intralipids will improve survival, and it did the opposite. They died of pulmonary hemorrhage. So we never start lipids before 12 hours of life. We start the next day. We'll start low essential fatty acids between 0.5 and 1 gram. We'll work our way up to 2 grams per kilo per day. We don't want to give more than that when we're liver protective. This minimizes NVN cholestasis and death. But protein, we're very aggressive. We have starter NVN at birth, get them at least on 1.5 grams per kilo. And then by the next day, we're working our way up to 3.5 to 4. Lots of good studies in late 80s and early 90s showed that if you're giving at least 35 calories per kilo plus this amount of protein, you're not catabolic. The key is the protein to prevent catabolism. And many of these babies are not ready for 60 to 65 calories per kilo for the first week. And so if you're trying to push them, they'll get hyperglycemic and fall apart. We also have photoprotector NVN. We know from studies that shielding parenteral nutrition for light improved survival rate in premature infants. And that was published in 2017. So skincare. So this was a 21 3/7 weeker, 20th percentile for 10 grams. You can see the skin soon after birth. You can see he's on first intention jet soon after birth. And there's his skin at 1 year. So briefly, we use a silicone polymer for the skin surfaces, and we use Mepitel to cover any wounds and cracks. And this silicone polymer only need to apply once a day. And we use a lot of micro EKG leads and protocols, and we avoid chlorhexidine because that burns the skin. We will use it on the lines, however, and wires. And we don't bathe these babies until they're 2 weeks old, and we just use only water. Blood pressure. You could talk about blood pressure. You can have a 3-day conference on blood pressure in these babies, but just to keep it simple, we aim for the 22 weekers for means in the low 20s and systolics 10 to 12 above that, unless there's issues related to the any type of echo findings. We look at the EpiPage trial or study of isolated hypotension. If you treated it, treated infants had significantly higher survival rate without major morbidity. So you don't really want to tolerate isolated hypotension. Now, we'll give the baby a few hours because they're transitioning, but you don't want to tolerate it for a long period of time. We do a lot of stress dose hydrocortisone. We have a protocol. It weans off automatically over 4 days. We'll give a little bit of fluid, but very slowly. If we see contractility problems based on echoes, we'll start dobutamine, or certainly we start if lactates are rising, or you see an enlarged heart. Dobutamine is primary inotrope. The hydrocortisone acts more as a vasopressor. This is isolated hypotension. Septic shock, you're going to need a lot more. Infectious disease. Everyone's on prophylactic nystatin to prevent fungal infection. All patients on antibiotics are on that. We also do prophylactic fluconazole, and we do at least 2 weeks, and the skin is keratinized. There's an RCT, a fluconazole for which reduced invasive candidiasis. We don't go for the full 6 weeks because if we can get the line, most of our lines will come out at 4 weeks, so we're not trying to keep any type of IV access. And so we don't do it for 6 weeks, but this has helped a lot once we started waiting until the skin is keratinized. We also do IgG screening. There was an RCT a long time ago in '92 that showed if you happen to have IVIG, now they did prophylactically, and it reduced infections in the 500 to 750 gram group. But you look more into the data, and the ones who were really getting affected were the ones whose IG levels were less than 200. So we don't do it prophylactically. What we do is we'll follow IgG levels weekly, and if it's below 200, then they'll get their IVIG. And we have a central line removal protocol that we not the art line, but the venous lines will get a dose of antibiotics. Endocrine, many of these babies need thyroid replacement, so they need to be screened again at 1 month of age. We've published on that in the past. And depending on how high the TSH level is and how low the T4 levels, will get on thyroid replacement. It's missed on the initial screens because the screens aren't sensitive enough to detect the lower levels of TSH. Like I said, many of these babies may need stress dose hydrocortisone, but some you find you can't, they fail weaning off of it, and some need the physiologic for days to weeks to months, depending on blood pressure stability. Cardiopulmonary failure, a lot of these babies might require inhaled NO. If oxygen requirement is more than 60%, mean area pressure is appropriate. Many of them have PPROM or pulmonary hypoplasia, pulmonary hypertension, or infection. So I looked at today I looked at since 2018 to 2022, 55% of 22 weekers required inhaled NO, 46-23 and 37-24. I can't differentiate between early and late from the database. They're on probiotics, delayed cord clamping, aggressive phototherapy. From this trial here, it's a neuroprotective strategy. It reduces overall NDI and importantly, profound impairment. And I chose this because we have the targeted echocardiography service since 2018. We use it to look at significant shunts, pulmonary hypertension, ventricular function. In the first week, we'll use acetaminophen for the hemodynamic significant PDA. If that doesn't work, because we're not trying to close it completely, we just want to reduce the shunt, trying to close it now, second, third week into methicillin. And if that fails, eventually they would get the coil if it's still significant shunting. It's important to pay attention to mortality. We don't accept extreme prematurity as the cause of death. So this is what we're constantly working on, trying to figure out how we can, infection is our leading cause, but most of it's early onset sepsis. These babies are being born with positive blood cultures, Klebsiella, E. coli, so forth. But they're high risk of neck. You've got to go really slow with the feeds. And we've been doing things to reduce FIP with a more aggressive, paying attention to inspissated meconium and getting rid of SIP. IVH, again, it's really dependent upon antenatal steroids. If we have that in grade 4, we'll redirect care if the parents want. It's hard to do much about asphyxia because we don't section for fetal distress, but even term babies, we can't figure out when to section. Importantly, with the JET concept, respiratory failure is only responsible for 8% of the deaths of babies born at 22 weeks. So in contrast, is 8% good or bad as the cause of death? I would say it's good because if you look at the leading cause of death in the preterm erythropoietin neuroprotection trial, 941 infants, no 22 or 23 weekers in there. Respiratory failure was responsible for 60% of all deaths at 24 weeks. So I would say in the same population, roughly at the same time period, you should have a anti-value trauma policy. Inborn morbidity, severe IVH is not 100%. It was 23%. Cystic PVL 6%, BP shunt 3%, neck 12%. We have very aggressive avoidance of our ROP requiring intervention was only 9%. If you look at Japan and Sweden, it tends to be closer to 40%. Okay. Neurodevelopmental outcomes. If we look at all 22 and 23 weekers, severe NDI was 11%, and the small number of 22 weekers, it was 18%. We know from Genevieve Taylor's work, looking them at from age 2 to age 10, this reduces by 67%, so there's a large shift. Other issues, most of these 22 and 23 weekers end up feeding just fine, so only 8% needed G tubes. And like I said, only in this case, 3 out of 42 in this study needed a VP shunt. And I just wanted to show, here's a 23 weeker that had Candida sepsis back before we did the fluconazole prophylaxis. And this is her prior to going to college. So survival is extremely difficult and not hopeless. So I'd be glad to take any questions now. Sorry for running over.
I think the fellows have the priority to ask a few questions, although we are not so experts. But I had a few questions, if actually too many, but I think I need to rewatch this presentation. Thank you so much, Dr. Klein.
Thank you.
First of all, I would like to ask from the back, like when you talked about the rescue nitric oxide therapy, there was like this trend. That's what we learned about the INO, that avoided preterm babies, they are so sensitive. I was wondering, what dose do you follow when you started? Would you start with the 20 ppm, or no, you will start with lower?
So that's, so, and how do I know? So it's interesting. We know from all the RCTs done in the 90s that it did not reduce, they were looking at reducing the incidence of BPD, and that was not found. And there was no increase in morbidities either between the two groups. Now, if you have the access to the hemodynamics team, we can then say, oh, look, they have pulmonary hypertension. And so, sometimes we'll start at 10, sometimes 20. It tends to depend on the faculty, it's sort of 10 to 20, and how quick the response is. And the quicker the response, you should be, and many times they respond within minutes of starting. So I think you don't want to wait, very long to bring that dose down. And so I think, you always want to use the minimal effective dose, but at the same time, you want to wean it so quickly that suddenly you reverse the shunt again. So it tends to be, so I have nothing against starting at 20 or starting at 10. I don't think we have great data to say that once you get the effective level, I guess the issue would be, let's say you start at 10, you don't get it in effect, and then you might need to go up because maybe you're having trouble getting it to diffuse across the mesenchymal tissue. So, if 10 doesn't work, that doesn't mean that the problem isn't pulmonary hypertension, especially if you have echo confirmation of high pulmonary vascular resistance. So that's a difficult, question. I think the main thing is many of these 22-weekers will have pulmonary hypertension, but within a day or two, they suddenly switch their direction. Now they're flooding their lungs. So you have to be ready to come off pretty quickly.
Exactly. Actually, I'm saying this question because I attended a couple of months ago, like Dr. McNamara mentioned one of the cases in your unit, and he started with the 5 ppm. So for me as a fellow, like we usually start with the 20s. He mentioned that the sensitivity is totally variable and minimal dose might be more than enough. That's why I'm asking.
Yeah, I have, nothing against, we don't know the exact dose to reduce the PVR. So, it all depends, are you starting it because we're getting our 18 to 24 echo and they see some high PVR, but the baby's doing well, or you've given surfactant, you're on 100% oxygen, your SATs are in the 40s to 50s. Your X-ray is adequately inflated, you have a good blood pressure, I'd probably be starting more like 10 and wanting to see an effect. Usually you see the effect within 5 minutes. So if not, you might need to go up. You have to start on 20. We just don't know. But I think, I would tend to think 10 is fine to start with.
Okay, I think now Dr. Yi has a question.
Thank you very much. Excellent presentation, Dr. Lei. So I'm sorry to keep you late.
No, I got all day for you.
Oh, good. Thank you. I have two questions. My first question is about the time of your extubation around 31 weeks.
Okay.
What's the percentage of those baby received the DART protocol steroids? And that's the first question. Second question is, those small baby were intubated with 2.0 tube. At what age your center considering upsize the tube?
Okay, so the upsizing, the median time of upsizing was around 4 weeks of life for the 2.0 tubes, but only about half got upsized. So either the other half were getting close to a trial of extubation, or were doing well enough that people felt no need to upsize the tube. So half did not get upsized. At 2.5 tubes, only about 12% got upsized. Now, I wanted to talk about that. A quarter of those babies are extubated before 29 weeks post-menstrual age. And, it's the median is 31, but it doesn't mean you wait till 31 weeks. So the question is, when we're thinking about extubating the babies, we start to think about the 22-weekers being extubated. We start discussing it around a month of life, kind of between 4 to 6 weeks of life. And at that point, we're now talking they're 27, 28 weeks post-menstrual age. And what we want to see is, one, we want them to have any issue with the PDA hopefully has been resolved. So that's not an issue. Also, we want to make sure that they're tolerating their feeds and they no longer need a central line. We want to say that they're on 50% or less oxygen and not having, bad desaturation spells requiring, constant intervention. And we want most of them to have doubled their weight. So if they're 400 grams, we want them closer to 850 grams. We want to make sure they're growing well. We don't say, okay, you don't hold everyone automatically 31 weeks. So now most of them, when we do go to extubate, will get we use 3 different protocols in terms of lung disease. So one of them, the most gentle one, is the hydrocortisone protocol. It's a 10-day course from the Neonatal Research Network. We published on this. The network published on it recently, and it was being used to reduce BPD, but importantly, it improved extubation success. So we still use it because we want extubation success. And so, if the lung disease is not that bad, we will give that. And usually you see the impact within the first 4 days. So the hydrocortisone, they'll be extubated and then they'll continue it for the full 10 days afterwards. If there's someone with a lot more significant lung disease, let's say they got the hydrocortisone and nothing happened, then people might decide, okay, I'm going to do the DART protocol. Often the DART protocol, if they're bad enough to need one DART protocol, invariably at some point they'll have to have another one so they don't backslide and end up back on the vent. So it's not unusual to have a DART 10 days and then a week or so later you might have another 10 days. If they're really bad, the work by Beverly Brzezinski that did a pulse dex course. So someone that we feel is really high oxygen, very inflamed, did not respond to surfactant. The PDA is not the issue. It's just really this baby cannot, as their antioxidant defenses are minimal. They may get a pulse dex, which is it's 6 doses over 3 days, which tends to work after 4 doses very effectively, reduces any subglottic swelling. So it has to kind of be individualized, and but I think the main thing is trying, the good thing with the jet. So we leave everyone on the jet till they're extubated. So we just don't want to, really use tidal volumes much more than 0.5 ml per kilo until unless we have a baby whose main issue is their apnea is so bad that people are bagging the baby all the time and their lungs aren't that bad, but it's their central apnea is just really immature, brainstem, then we might put them on conventional. So I don't have the exact percentage. I know, and I've looked it up. I know I have it in other emails. It might, and it might be around 60%, but in terms of DART, I'd have to look it up, but I think you can individualize it.
Is your center start prophylactic hydrocortisone for the Promilol protocol?
So no, so we don't do the you're talking about the Premaloc, right?
Yeah.
Yeah, because the risk of sepsis, because one, it's a long course. So we only give the hydrocortisone for the isolated hypotension. And we have a very, we noticed, and since we use it a lot, we created a automatic weaning schedule. When I left the weaning up to the individual team, it would get forgotten. And so it's an order set, it's a 4-day course. So the baby has some isolated hypotension. I mean, a lot of times, 3 hours after that first dose of hydrocortisone, the blood pressure is fine. And then they wean off of it. And it avoids, we made the course so we're not using enough to cause significant hyperglycemia. And then it's sort of a transition problem. And so most will come off it, but there's a small subset, probably 10%, that still you try to come off it and then they're falling, they're having trouble maintaining blood pressure, ventilating, oxygenating. Then they'll get re-stress dose and then they'll be put on physiologic, and then they'll be outgrown over many months. So we have a small subset of kids that's on physiologic. We're not even weaning, we're just letting them outgrow it. And then when they get to 36 weeks, we'll talk about, trying to wean them off and then repeat an ACTH stim test and see if they need to go home on it or not. But it's interesting. The ones that do go home are all off of it by a year of life. The ones who go home on Synthroid are all weaned off when they're 3 years old.
Thank you very much.
Thank you.
So
I
thanks a lot.
think, yeah.
So thanks a lot for the nice lecture. My question is about delayed cord clamping, which I expected that most of them wouldn't be receiving delayed cord clamping, unlike what I understood from the presentation. And the second thing that also I noticed that the 82.
So let me back up. I'm going to back up. So actually, since 2014, most are getting delayed cord clamping. Most of them are coming out vigorous enough. Most aren't coming out. Most are coming out doing some breathing. So if they're so we go ahead and do delayed cord clamping. We don't try to get 60 seconds. Most of them at 30 seconds, we start to tell the OBs, hey, we need to get them to us. So most probably get between 30 and 45 seconds. And I don't know if that paper's been published yet, but we look back more recently, and looking at our data, and the tiny babies who got delayed cord clamping, it significantly reduced IVH. So I'm very strong believer in doing delayed cord clamping. Obviously, if the baby comes out with a 0-1, if they're not breathing, it doesn't do any good, and we've not really have a system that we can leave them connected to the cord and ventilate them. So hopefully the OB stimulating them and getting them to breathe a little bit reduces the PVR enough to get some of the delayed cord clamp transfusion over. So we do try to do delayed cord clamping. That's the initial goal. And I know that paper, I can't remember the exact percentage that got it, but it's pretty high.
And I think although you are using size 2 ET tube, but I noticed that you don't shorten it. Am I right?
Yeah. So there's a benefit for not shortening it. I mean, it's very easy then to manage the patients, and it's very easy to avoid extubating with them. These babies are being supported by the ventilator. So the jet, doesn't really have any issue with getting the gas in, and there's no issue as long as you have enough E time, prolonged IE ratio. There's no problem with passive elastic recoil. And actually, we want these babies spontaneously breathing. We don't do hardly any sedation at all. So you want those babies spontaneously breathing. And it's really, the extra, you think about the major thing that impacts resistance to flow is radius to the fourth power versus it's linear, so, cutting off once, a couple centimeters off that ET tube makes a pretty minimal improvement in resistance to flow versus obviously being intubated with a bigger tube greatly reduces resistance, but it's just not an issue in this population. So we never cut any of our tubes at all. It was an issue a long time ago before we had continuous flow ventilators and pressure support. So in the 1960s and 70s, it was an issue, but in the 1980s, once we had continuous flow, it really wasn't an issue.
Right.
So it's a theoretical issue, but it'd be completely different if you're just saying, okay, the baby's not on a ventilator and you're just asking him to breathe completely through it with no support. Yes, it's a problem, but it's not a problem on the jet.
Thank you very much. I would just have one more question. What PPV devices do you use in the resuscitation? It is the flow inflating bag or T-piece or self-inflating?
Yeah. So we use the flow inflating bag. I think it's important for fellows to learn how to manage a flow inflating bag. Yes, it's more of a challenge, but it allows you to get some sense of compliance. Obviously, the easiest are the a T-piece resuscitator and the self-inflating bags are much easier to use. But I think in this population, it's really good to get a feeling of of how to maintain that PEPA5 and get a feeling as you bag and looking at and focusing on the chest wall movement. I tried not to get them to focus on look at the baby, constantly saying look at the baby. So and look at the response to look at the heart rate and the response. So rather than saying, I got to aim for a certain peak pressure. We have this sort of bag in the teens and maybe work it up in the low 20s, so the heart rate's coming up and you see a little bit of chest wall movement. I have nothing against, if this, I don't think, is there any real difference between whether you use T-piece resuscitator or flow inflating bag? Probably not. I mean, the one thing we can certainly say is, there was the large SAIL trial, the sustained inflation trial, which was stopped, years early because of the 5-fold increase in mortality. So we know doing a sustained inflation, which works in adults and might work in term babies, but apply to premature babies, especially under 26 weeks, caused huge increase in mortality.
Thanks a lot.
Thank you.
Thanks.
First
Thanks.
of all, okay, Deepak, go ahead.
Dr. Lewis, go ahead.
Go ahead.
Yeah, thanks, Dr. Klein, for that great talk. So
Thank you.
one challenge we face here, like in our NICU, is that as babies, particularly as they get older, we have to use a lot of sedation when they're on the jet. And I just heard you saying that you do not use much. Like as they get older, do you see that as a challenge when they remain on the jet?
So that's a cultural thing. I mean, so when centers tell me they have, I mean, we have a lot of babies on the jet that, may be 6 weeks old, 7 weeks old, 8 weeks old, which means they're just 31 weeks postmenstrual age. We want them over breathing the machine. So what happens is the nurses, suddenly the nurses will think, I see the baby breathing, that means they're fighting the jet. No, they're not fighting the jet. We want them breathing. So we want the babies over breathing the machine all the time. The baby spontaneously breathing stimulates lung growth. So, and we want, so the only time we've ever used, we might use some PRN sedation if the baby is having a severe desaturation episode associated with severe agitation, where they're desatting into the 50s and 60s and they're flailing. But breathing over the ventilator, we don't worry about. We also don't, a lot of people get fixated, there's certain alarms on the jet that are way too sensitive. For example, but the alarm limits for the pressure alarm limits, the mean area pressure alarm limits, and all these things fluctuate all the time depending whether the baby's breathing against the machine or not. So we tend, we don't try to change anything based on those, like the servo pressure. The servo pressure alarms all the time intermittently depending whether the baby's sucking a breath in or breathing out. So we just don't stress about those as long as we don't try to sedate the baby out of spontaneous breathing. So it becomes a cultural thing where, people will come and see see the babies on the jet and they're all spontaneous breathing and they're all moving. And we're doing kangaroo care. And, so the alarms go on and off on the jet. As long as we're not bradycardic or deep desats, we don't, worry about sedation. So I think what happens is there's a feeling like any baby on high frequency has to be sedated. Well, we don't automatically sedate kids on conventional. So I don't know if, and we want to see them breathing. So they think, oh, if they're breathing, if we can see breathing on the jet, that's bad. No, that's good. The more the baby spontaneously breathes, the better, and the more likely we're going to build up enough strength to come off the vent successfully. So it's a cultural thing. And it's, I mean, sometimes they just have to talk to nurses at another center who say, oh yeah, we tend not to use much sedation. I mean, it's almost, I'd say it's extremely rare.
Thank you.
I have a question. First of all, thank you very much. It was very nice talk.
Thank you.
Like you lost half of the babies from the sepsis or infection. It was like kind of like.
Well, not half. Let me back up. It's not half the babies, right? I mean, survival is 65%. If you look at the percent, so the question is, what do babies born at 22 weeks die from? So we're looking at, we're not saying, so I try to, some people sometimes look at that and they think, oh, wait a minute, half your 22 weekers. No, we're talking about out of the 35% of the 22 weekers that pass away. Overall, what did they pass away from?
Mm. My question is that the source of the infection was like a kind of coming from the mom side or from the hospital side, and the second one is what is your a central line policy? Do you have a kind of could you mention about any central line policy?
So if we look at, the babies that the cause of that's related to infection, most of it is because they're born from chorioamnionitis. So it's early onset septic shock. And it's coming from obviously the placenta from the mom, from chorioamnionitis, and they're having blood cultures positive for E. coli, multi-drug resistant E. coli, Klebsiella pneumoniae, and early onset GBS. In terms of, late infection, I would include any NEC as in there. So there are, one of the, cause of death, as I said, about 14% of these babies could have NEC, or they get a focal intestinal perforation that leads to peritonitis. So we've worked, I'm showing you stuff over 2006 to 2021. We keep reducing, the deaths by learning what is the cause of death and how to prevent it. So I'm giving you kind of a big overview, but as we've done things to reduce the causes of death, such as the IgGs, when we looked at some of the kids who got late onset sepsis, their IgG levels were too low. Now, the source, our central line associated bloodstream infection rate's pretty low. So I think a lot of it probably is coming from lungs. But some also, could be from central lines. And a lot also is from bacterial translocation from the intestine. So it comes from a variety of places. And I think that's one of the main struggles that you get through the pulmonary issue, how to prevent, when I looked at the incidence of late onset sepsis in this population, it's about 22% in terms of developing an infection at 22 weeks. So it's a high risk population. Now, the central line, we know we have the nurses we have very aggressive care in terms of changing the central line sterilely when they get changed. But we don't push, one of the things when I talk about balancing, the goal is not to have that PICC line out in 2 weeks because your push feeds too fast and you end up having problems with NEC. So, to me, it is much rather about a much lower incidence of NEC and potentially, and to do that, you have longer central line days. So on average, the central lines are in probably about 4 weeks because it takes, most of these babies cannot get on full feeds. We try to get them to full feeds by 10 to 12 days. At 22 and 23 weeks, you'll end up with a lot of trouble with NEC or focal intestinal perforation, or you get SIP because you're giving indomethacin, or our neck rate is down now like 1 or 2 patients a year because the other thing we found that once we had better hemodynamics telling us, oh, we have reversal of flow during diastole, descending aorta, don't be pushing feeds on those babies, go to trophic and just get the duct flow, get the flow back to normal so we're not shunting away from the gut. So, even if you have only 10% of the babies die, it's good to know what's the cause because that's how you improve you don't know the cause of death. In a lot of places, they just go, well, 22-weeker dies because they're 22 weeks. Well, you can't make any improvement. 23-weeker dies because they're 23 weeks. Well, if you don't know what they're dying from, how can we improve? So if your survival, let's say at 23 weeks is 50% and we want to get to 75 or 80, what are the 23-weekers dying from? So we constantly look at that and then, keep retooling. Now, the numbers are so small, I like to talk cumulatively, but certainly things have changed. So yeah, neck rate may seem high, but that's, dropped off. IVH rate, it all depends on the antenatal steroids. And we're hoping, looking at some other data with a little bit more hemodynamic fine tuning, it seems like the IVH rate is also dropping, trying to avoid large ductal shunts in the first couple of days of life if they have ductal physiology. Okay. And so I know, I don't know if that helps, but my concern is people get fixated on central line days and they push feeds So I've talked to centers where they go, well, we don't worry about our neck rates average, it's 5 or 6% in babies VLBWs. I'm like, well, but you could be at 2%. So is it better to have, central line days, 7 days longer and cut your neck rate in half? I think it is. But the hospital doesn't pay attention to neck. Neonatologists, we know how horrendous NEC is, even if you survive it. So with a short bowel syndrome. So it's hard to, to get focused on that. And like I said, we do track CLABSI. I can't, and I don't, so it's all the balance.
Thank you so
Thank
much
you.
again. Thank you.
Can I ask one more question? I know we are like.
Whatever you want.
Okay, thank you so much. Actually, it's about the jet. Like, what would you do when we are, like, for example, the second, third day of life, when everything is nice after giving the surfactant, and the delta P is very tiny? Like for example, let's say PEEP is 6, and now the delta P is almost 8, 9. Would you shift to the conventional, or no? You will keep.
So,
how would you do
so,
this?
so you so we have to decide, what is this patient, right? Is this a 26-weeker? Well, maybe he's ready for extubation. If this is a 22-weeker, what we would be doing would we bring the rate down to 240. We would say, this is great. We'll go to a rate down to 240. And, as long as that CO2 is not below 35, we would just let that 22-weeker grow. And we'd be advancing feeds, and hopefully the baby's stooling and not having death spells, and the glucose is stable, so we could give more calories every day. So at 22 weeks, we would just be letting the baby grow. 26 weeks, okay, that delta P is good for extubation. I can tell you what has happened in the past is, let's say the gent's completely failing. And again, this is 22 and 23 weeks. And failing in the sense that, we're on a rate of 240 and we are, 10/4 and the CO2's in the 20s at a rate of 240 nighttime, then we would go to conventional. But we'd have a low threshold for going from conventional back to the jet. So it's very interesting. What will happen is they'll go on conventional, and pretty soon you're cranking settings up because the CO2 now has risen, because it's just not as effective at ventilation. And as the CO2 is rising, because you're getting more and more lung injury from 5 per kilo tidal volumes versus 0.5 per kilo tidal volumes. And then within 12 hours, we're back on the jet, and actually the settings are higher and they end up staying higher. So it's, again, is it a 22-weeker in the first 2 weeks of life? We would ride it out unless the CO2 is, low enough to impede cerebral perfusion, which would be less than 35.
Yeah.
If it's 26 weeks, well, then we should be extubating. For us, we'd go to NAVA.
Yeah. The other question is about, I just want you to correct me if I misunderstood it, about the second dose of surfactant when there's a slump phase. So is there a percentage, like, because it's really witnessed, there is the first week, which is the honeymoon period, and then the second week we start having the higher FiO2. Is there any threshold for this surfactant administration? Is it radiological? Is it the FiO2? Is it compliance?
So it tends to be, you're on more than, you're now above 40%. Your X-ray is, you look at the X-ray and you're seeing a diffuse, it's not a focal atelectasis, you're seeing kind of diffuse microatelectasis. You're saying reticular granular pattern. In order to maintain the same CO2 and the same saturations, you're going up on the delta P, you're going up on the rate. Your baby's having, the X-ray just keeps getting worse. That's when and you've ruled out the PDA. So is it getting, is the lung compliance worsening because you have pulmonary overcirculation? Now you can have both. So you may need to treat that. And so sometimes we go, oh, look, we got pulmonary overcirculation. We'll start treatment on that. And we're still getting worse because it takes time to fix that. Then we will still give, more surfactant. What we don't want to do is just give the surfactant without knowing what's going on with, do we need to treat the PDA also? Or are they getting worse because they one time, the set of twins I showed in the beginning, they got 7 days of antibiotics and they started getting, and then 48 hours off antibiotics, things started to change. They got low hypoglycemic And we reworked them up, and the blood culture grew E. coli, similar to what mom's blood culture had as in her urine. But the initial blood cultures were negative because mom was on latency antibiotics. So sometimes these tiny babies, when they start to deteriorate coming off antibiotics, you've got to also think about, we always restart the antibiotics because many times 7 days is not adequate, but it's hard. It's rare that you got a positive blood culture at birth unless they're so overloaded with bacteria and the parent hasn't gotten enough latency antibiotics. So we try not to spend a lot of time with beating up the lungs and waiting, okay, now you're on 100% oxygen and now try it. It sort of defeats the whole purpose. Now, what's interesting, there were 2 randomized controlled trials of repeat surfactant therapy, one the Tolsurf trial and one by Hackasset out of France. And the problem is they didn't show acute benefit. They showed long-term benefit in terms of reducing like wheezing and readmissions. But part of the problem was they gave it to everyone. So if you give a drug to 8 out of 10 patients just because they're on the ventilator and you're on the ventilator with good lungs, putting surfactant in is going to make things worse. So that's that. So people will tell me, well, we're not going to give a repeat course because here's the RCT. And I said, well, read the RCT. They gave it to everyone. We're just asking you to give you ones who are showing this. And there's a lot of supportive papers showing if you measure surfactant activity, it's low, and et cetera, et cetera. So, and I mean, and the other interesting thing is if you do repeat, course, it doesn't get better like in minutes, like it does with pure surfactant deficiency. It usually takes what we showed like 12 hours to get better. So you can't go, oh, we gave it, the baby's not better. And the next morning you'll see you're better. And then 24 hours later, you're better, and 36 and 48. So the improvement continues for 48 hours because the distribution is so much harder, with these lungs that are obviously suffered some damage because they're not designed to live in a gas atmosphere. Well, I don't know. I know there's more hands. I don't see the. I'll let
Dr. Lewis.
if you can figure that out.
Yeah, no, I think even beyond your talk, I think we as a group, I think really appreciate you coming and talking to us because
Thank you.
I think it's so amazing the work you have been doing so far. And I think we as a group look forward to achieving, right, the goals you have achieved. And you're one of the centers around the world with the best survival rates for the small babies. So we in our center, we are kind of trying to embark on stating 22 weekers. So far, we have been doing slowly. We have come down to 23 weeks, but we are kind of preparing. We're pretty close to starting the stating 22 weekers. So do you have any kind of quick tips for us?
Well, so, I don't know if I sent you any of our skincare guidelines, and if I haven't, I think I did, but the skincare is really critical because the 22-week skin is so gelatinous, and that silicone product makes a huge difference, and the Mepitone makes a huge difference. So I think the other thing is that they end up needing, even if you use humidity, you still need more fluid. And sometimes with too much humidity, 100%, the skin becomes very macerated and breaks down and doesn't heal very quickly. So I tell people that use humidity, just use less. So, some people say, well, we use 100%. Okay, well, try 70% at 22 weeks and maybe the skin won't get as bad. And then a lot of the places that use humidity, like Japan, they'll go to 60%, but they'll wait for X number of days to go there. And I think it's better to go sooner, allow that skin to keratinize quicker. But when you use less humidity, you're going to have to give more fluid, but they don't get fluid overloaded because you're giving more fluid to keep the sodium under 150. There are people that will use humidity, but they don't do any change in fluids. They don't follow the electrolytes, and pretty soon the sodium is 169, the kidneys have shut down, and the baby dies from AKI. So as you get lower, you still need to follow them. The first 3 to 7 days is really, you need a lot of fine tuning. And then once you get to the first week, you can start to back off. I think the other thing is is just electively say, hey, at 23, we don't say everyone gets a 2.0. Usually we'll do a 2.5. If it doesn't pass, we're ready to put a 2.0 in. At 22 weeks, it's just not worth trying to, always get that 2.5 in because it gets frustrating. The fellows will say it's going in. Well, but the obstruction is below the cord, it's subglottic area. I know I saw the cords, I know it bounces off, and then you could risk, tracheal trauma. So 22, just do the 2-0, there's no stress, and it's a lot easier. The baby's either ready to be extubated a month or needs a couple more weeks, then we'll say, okay, we'll exchange it. The jet doesn't care about a leak. That's a good thing about the jet. When you're on a volume guaranteed type conventional ventilator, it goes crazy if you have a leak. The jet doesn't care about the leak. It doesn't matter whether CO2 leaves the lungs around or through the tube. I guess the other thing with 22 weekers, the key is just not pushing them hard. So electively intubate, let them grow for a month. Don't push them off the ventilator. Don't push to try to give perfect calories in the first week. You're going to get hyperglycemic and have all these complications related to hyperglycemia. The insulin trials didn't help anything. They just made the babies fat. There's an advantage of needing more fluid because you could give 60, 80 per kilo, 5% amino acid, and you're with good protein. And it's okay to be on low GIR and low calories that first week because the babies are not expending much. You're doing all the warmth for them. You're doing all the ventilation for them. So it's rare. Most of these babies don't get to 65 calories per kilo until like 7 to 10 days of life. And we don't worry about it. Oh, we're on 35, but we're on 3.5 grams of protein. The studies show they're not catabolic. Oh, we're up to 40 grams. I'm happy. I'm 40 calories per kilo. I'm happy. 45. I mean, we'll slowly keep working our way up. The baby will let you know, hey, I'm moving more, I'm breathing more, my brain is growing. I'll now metabolize that glucose. So we try to keep the glucoses, ideally less than 150. I mean, the main reason we chose 150 because we want to avoid above 180. So we tend not. I think I get people freaking out too much about 152, but that's Iowa. So and then the other main thing that a lot that people have found, a lot of these babies has inspissated meconium. So we tried. It's really hard to get that inspissated meconium out, and so if you feel like, gee, we're in the second week of life, and all we're seeing are smears, even though we've been doing some gentle feeds and we've given some glycerin, we can try to get I've got our radiologist, they'll come up and do a contrast lower GI in the NICU. But if you can't, sometimes I got them to come up. Other centers, the radiologists won't come up, but sometimes it's worth bringing the baby down to clear all that inspissated meconium, because a lot of these babies can have this focal intestinal perforation. Surgeons go in and they always find inspissated meconium. And I know that the Korean literature and the Japanese literature have talked about that too. So the gut motility takes a long time to come in. So that's why you just can't push the feeds, or you've got to clear that meconium at some point. So I guess that the main thing is just don't push them. I think that's the main thing at 22 weeks. And just don't push them off the ventilator, don't push the full feeds, don't push the central line out too quick. Don't push them off antibiotics too quick. A lot of these patients, I would say normally almost all of them get a minimum of 7 days, and they might go longer if we think infection's a problem. A lot of centers that have gone to 22 weeks try to treat them like a 26-week who's having a 48-hour rule out, and maybe delivered because of preeclampsia or be delivered for some maternal reasons. Sure. These babies, they do 48 hours and they tell me, well, all the 22 weekers are dying at day 5 of life. And I'm like, well, it's because they're septic. Oh, but the initial blood culture didn't grow. Well, the literature shows only about 11% of the initial blood cultures grow. So you can't just use only that as your indication for continuation of antibiotics. And when I looked at the adult literature, many times it's not 100% in the adult literature. The adults draw 40 mLs of blood, and some of the data on septic shock adults is 25 to 35% positive blood culture. So we expect our babies whose total blood volume is 40 mLs to always have a positive blood culture. So you have to look at the big picture. So I think looking at mistakes people make is pushing too aggressively, waiting too long to intubate, pushing them off the vent too quickly, pushing feeds too quickly, pulling central lines out too quickly. Sometimes on average, we tend to leave the ART line in probably 10 days and hopefully get the UVC in roughly around the same time in good position, and try to get the central line in, the PIC line in. So it's you just sort of, as it's what you do for 23, but the skin is an issue.
Mhm.
And then everyone has to be on board. You can't have the nurses have to be supportive of this, because it becomes a self-fulfilling prophecy. And even if you do well, I mean, 6 or 7 out of 10, you could have 3 out of 10 die in 2 weeks or 2 months, and then people focus on that and don't focus on the ones that you've given a chance to live.
Mhm.
So just don't, just take your time.
Thanks a lot for your time. It was really an amazing lecture, and we
Thank
really appreciate your presence here. Thank you.
All right, thank you. And then feel free, and you guys can, if there's more stuff I haven't sent and you need more stuff, just let me know and I'll share whatever we have, if I have it.
We really appreciate your support. Thank you.
Okay,
Thanks a
thank
lot.
you.
Have a great day. Bye.
All right, bye.